All right, everyone, thank you for attending the webinar today. My name's Holly Marita, and I'm with David Insurance in Wisconsin. Just a few housekeeping notes. If you have questions, please put them in the chat box, and we'll try to get to them at the end. We're excited to bring you our four-tiered webinar series, Understanding the Four Components of Your Self-Funded Plan. Today's webinar is part 4, focusing on the impact an independent TPA can have on your self-funded plan. Our guest speaker, Ken Vegas, is president of Enterprise Group Planning since 1996. Ken has almost 40 years of experience, and EGP, is the exclusive TPA for Ohio for U.S. Health and Life Insurance Company. Thank you for joining us today, Ken.
You're very welcome. Good morning.
Morning. Go ahead.
All right. Well, thank you, everybody, for joining. And our subject matter is, of course, the advantages of working with an independent TPA. And my company, Enterprise Group Planning, we are an independent TPA. We have been in business for over 40 years, since 1974, actually. So we've got quite a bit of experience in working for self-funded employers, also working for and representing insurance companies as a contracted TPA for carriers. So we've got experience in the carrier world as an independent TPA working for independent health plans. And we believe at our core that there is a distinct advantage and a value proposition that we offer as an independent TPA. And we do not, a couple of things about our company. We do not market directly to employers. So we are primarily focused on serving the broker consultant community and becoming available as a resource for them to serve their customers. We consider ourselves to be a specialty, somewhat of a niche TPA, because we are innovative in many ways that we're going to talk about here in the balance of this presentation. We are old school to the extent that we have a business model, a business philosophy that really sets us apart from our peers and what national TPAs, or more importantly, commercial carrier owned or sponsored TPAs really can provide. And that is that we're old school and that we still staff our organization with professional, experienced people that can really make a difference in the value prop that we offer, which is really personalized customer service, but most importantly, a focus on claim and risk management. So our claims department, for example, the average length of service of the people that are working in our claims department is over 18 years working just for our company. And that gives us a distinct advantage in that area of claim and risk management. So we have the sirens go by, pardon that. Although we have the best technology available to us, so a very robust claim system that's well known in the national community as a substantial claim processing system, and a very interactive web portal that provides all the latest technology features to not only the HR directors, but the participating members. We are old school in that we staff ourselves with these experienced professionals. They work directly with the participants, with the HR staff, with the broker consultants. They get to know the people that are utilizing the plan and can assist us in looking for opportunities for claim and risk management. We intentionally are very careful and have a low auto adjudication rate with our sophisticated claim system because we want that interaction. We want professionals looking at the claim activity and looking for examples where we can inject ourselves. We take our role very seriously as a third-party administrator and as a custodian of an employer's plan. So that's why we set our business model as we have. And again, it's unique in that it's not a model that can be duplicated by the commercial carriers in their ASO-related TPA functionality. The first slide that you see on the screen is the profile of our organization, which we've just talked about, and all the services that we do, which really are all services related and necessary for the management of an employee benefit plan. We consider ourselves to be a hub for all the necessary services provided by us and by integral third parties that help us bring value to the plan management. We work on that process collaboratively with the brokers. We're independent. We're not tied to stop loss carriers. We're not tied to any other vendor. So we can always vet out and test and bring to the table the very best available resources in the marketplace. And I mentioned collaboratively working with the broker consultant. We have no reluctance at all when the broker consultant has a preferred relationship and they'd like them to be part of that process and connected to that hub, whether it be a PBM, a wellness program, or anything like that. Some of the features that we bring to the table as an independent TPA, we can assist the broker consultant with managing customers in their transition to self-funding. Oftentimes, an employer, before they jump into self-funding, will buy a high deductible, fully insured plan. We can provide administrative services on an HRA plan and start to build a portfolio and an idea on the risk profile of a case to help evaluate their candidacy for self-funding. And then we also have a number of stop loss sources that can provide paper for level funded programs, aggregate only, that are very fully insured and are oftentimes considered a good stepping stone for an employer to make that first move into self-funding. Allow us to assess their risk, build the claims experience, really position themselves to transition to a traditional aggregate and specific stop loss arrangement. We think it's very important to manage every element of a self-funded plan, which includes medical, prescription, the premium stop loss arrangements, and provide that element of accountability. In my view, in my experience, what you see from commercial carrier ASO modeled servicing of self-funded plans is they take a very limited role in terms of adding value and adding an element of accountability in there for the claim and risk management, particularly provider accountability. Most national TPAs or carrier-based TPAs rely on two things. One, the discounts that are provided by their PPO network or whatever contracted PPO network that they use. And two, their automated system as a method of managing claim expenses. And that falls woefully short in my mind. I touched on the value of having experienced people look at the claim activity, look at the utilization, look for emerging risks so that we can apply claim and risk management techniques. So we've touched on that. We should also touch on the value of PPO networks. I think most of you probably know, and it's an emerging accepted belief that PPO contracting in and of itself is flawed by its nature. There's nothing more frustrating than try to explain to a self-funded employer CFO why they don't have access to or why they aren't a party to the contract that they're paying for. They're paying to be a participant under a PPO network contract, yet the terms of that contract are proprietary. And even though they are not only paying the privilege of accessing the PPO contract, but they're paying the claims, the CFO can't access the proprietary terms of that contract in terms of what the rates are, the negotiated rates between the PPO network and the providers. Long story short, those PPO contracts really serve the hospital system as a primary party, primary interest in serving under the contract by the carrier and the PPO network, and they're set ahead of the employer, and the employer, of course, and their health plan should be the primary beneficiary, and PPO contracts just don't serve them that well. The other flaws with the PPO contract exist are that over time, there are outliers that are built into the contract. So even though on average you might see a 40% discount for most claims, a lot of hospital systems have negotiated outlier provisions in the contracts where if a claim fits a certain DRG criteria or the bill charges for a particular service exceed a certain dollar threshold, then that standard discount goes away and instead is replaced by what's considered an outlier provision in the contract at a much lower discount rate. Very frustrating to stop loss carriers. They're usually hurt badly by these because it often occurs on claims where they're on the risk and they're exposed to a much higher claim output payable amount because of those outliers. That, of course, has a trickle effect to the employer in terms of their future renewals, premiums on their renewals, potential exposure to laser, deductibles, and the like. So as an innovator, one of the things that we've been very proactive in doing is developing alternatives to the standard PPO contracts, which we're going to talk about in a minute. So again, highlighting the advantage of the independent TPAs. Again, on this next slide, you'll see we have a higher degree of customer service and professionalism. We don't staff with a phone bank, with a customer service bank, where the participants have to call in and talk to somebody different every time. We assign a dedicated claims adjuster to every single one of our customers' health plans. And that claims adjuster that's assigned to that case is responsible to communicate and speak directly to the broker, the HR team, and every individual participating member, which is a completely different model than you get with a carrier-based program. Again, that relationship building results in a higher level of customer service, but also assists us in the goal of being able to be in a position to claim and risk management, identify opportunities to assist patients to having access to a better source of care or at a more efficient pricing point. Independence of stop loss and other critical vendor applications. Oftentimes when you're dealing with a national TPA or a carrier owned or sponsored TPA, you're beholden to using their third-party vendor applications or their source for stop loss. And we're completely independent. So we're plug and playing in the very best value at any point in time, and then reevaluating that every renewal, making sure we have the very best of third-party partners to allow us to effectively do our job. We've talked about claim and risk management. We'll have some examples of that in a moment. And then I also mentioned alternative provider reimbursement models, which would be alternatives to the standard PPO contracting. The next slide here that we're going to look at is just sort of a visual of how we at the hub of the whole process, centered on the plan participant in the middle, we provide all the necessary administrative services in order to make the plan go, from eligibility maintenance to the dedicated claims adjuster, the patient advocacy support, both on a clinical aspect, but also on a billing and provider relationship management basis. And of course, all that is available by that one-on-one individual connection to our dedicated staff or through our portals, which again are representative of the best of technology that's out there. This next slide shows as a visual some of the third-party key vendor partners that we work with over the years. And again, they're plug and play, but some examples of those are PBMs that you see there. We have a relationship where we participate in a large employer coalition, and we could provide access to CVS and Caremark as one of the largest PBMs in the country. Through the rolling our block of business up through that coalition, we have the opportunity to bring contract pricing to an employer that has a health plan that has 80 employees on it or 100 employees on it. Pricing that really employers that have 10,000 or more employees are only able to get. So that's a unique position of advantage. We work with telemedicine providers like Teladoc, utilization management vendors like AIM, like American Health, and we use the technology of WEX Health for management of our Section 125 flexible spending programs and HRA management programs. So that's just a glimpse of some of the third-party vendors that we utilize. This next slide is a great example, real-life example of how we, as an independent TPA, inject ourselves in search for opportunities to claim and risk manage. So, I'm sure many of you wonder how we do that. Well, keeping an eye on the claim activity with experienced individuals is a critical component of that. This is an example here of one of our customers that utilizes the Cigna PPO network, which is one of the networks we can provide access to, of course, the national carrier-based network. And they also happen to use TrueRx as their PBM in this particular case. We had an individual newly diagnosed in the hospital with MS, multiple sclerosis. And the treatment that was prescribed by the physician at that inpatient confinement was an injectable specialty medication that was going to be administered once every 6 months. And they administered the medication the very first time upon diagnosis when this person was in the hospital. And the bill charges for the medication and the administration of the medication were $143,000. After the PPO discount, you can see that that charge was reduced to an allowable amount of $62,000. But again, pretty daunting expense factor, $62,000 every 6 months or twice per year for this injectable medication. So we immediately jumped into action, and before the administration of the second injection, we made arrangements to have that specialty drug delivered to the hospital from one of our specialty drug sources so that the hospital could administer it, but at our preferred specialty drug pharmacy rate. The hospital resisted, of course. They did not want us to do that. They threw up some barriers, including going out of their way to tell the patient that it was illegal for them to administer a drug to a patient that wasn't part of their own internal hospital pharmacy supply, which of course is a falsehood. And we combated that. We had a nurse, patient, advocate, case manager working with the family, making sure they had all the facts and understood exactly what we were doing. At the end of the day, the hospital eventually relented. They really didn't have a choice, but it took some persistence and determination in order to get them to do so. But the bottom line is the success of that was now the cost per administration, drug cost plus the hospital administrative charge every 6 months dropped to $21,000 and change. So here we're looking at a savings of over $40,000 every 6 months by us being proactive and making sure that the most efficient available care was provided in the most efficient setting at all times. So significant savings there for the employer's plan, of course, and likely have an impact on their stop loss coverage as well at a $40,000 savings every 6 months. That's an example of the type of work that we do by just identifying the nature of that claim. I could trust you. I could tell you, you could trust me from my experience that if that was a carrier-based TPA program, they would likely not even identify that as an opportunity. And even if they did, they likely would not have brought the drug in from another source, because again, they're serving and cultivating that relationship with the hospital. And in many cases, that's more important to them than the end user or employer. That likely would just sail by and the employer would continue to pay $60,000+ every 6 months. I can give you another real example of a similar situation, which is why we've been so diligent in pursuing alternatives to PPO contracts. We had an individual who was a cardiac patient at a regional hospital, had a cardiac event, who was stabilized by that hospital, and was able to go home. But the consensus was he needed a cardiac surgical procedure. And for that, he was referred to the major metropolitan specialty hospital within an hour and a half drive of that regional hospital. We, of course, signed a patient advocate and nurse case manager to make sure that he had everything he needed, had the records transferred up to that hospital. And then when he went up there to present himself for that surgery, they admitted him into the intensive care ICU. We were following the patient, as we always do with our nurse case manager. And after 3 or 4 days in intensive care ICU, we were pressing the hospital staff as to why he hadn't had the surgical procedure yet. And in a moment of absolute candor, the floor nurse there explained to our nurse that they were way backed up in the operating room, in their operating room schedule. They had more urgent patients. And because he was stable and being well cared for in the intensive care ICU, he was being pushed to the back of the line. Maddening and frustrating, of course, particularly in that this went on for 12 days. And then after the 12th day, he finally had a surgical procedure, did well, and was discharged. Well, the bottom line is we knew that he wasn't receiving any care, and we knew he could have been at home this whole time. So after we got the bill, and the bill included 12 days of ICU charges at $70,000+, we immediately reached out to first thing we did was requested a copy of the chart from the hospital. And the hospital creatively, of course, sent us the chart from the date of the surgery on. And we politely and sternly requested the chart for those first 12 days, eventually received it, had an independent clinical review done of it, which confirmed what we already knew. He got no care while he was there in those 12 days. He could have been at home, and he was really just sitting there. So we next reached out to the network, which was a national carrier network, again, and said, we'd like some help. We'd like the hospital rebuild us. Here's the story. Here's the evidence. Here's what happened. We're not going to pay those first 12 days, and they shouldn't be billing for them. So the network got back to us the next day and said, sorry, but our contract with that hospital is that we will pay his bill. And if we were the carrier on this for this claimant, either on our fully insured plans or with our self-funded ASO administration, we would pay those 12 days because we're required to by contract, and by extension, you should do the same. Which, of course, struck alarm bells to me, and again, is evidence that these carrier-based TPA ASO models don't really do what they should be doing in terms of claim auditing and claim risk management. Again, they're beholden to the providers. So I said, well, we're not going to pay that, and working collaboratively with the stop-loss carrier to ensure that they would cover us and support us, we challenged the hospital. The PPO network said, well, you're on your own. You shouldn't be doing that. The hospital called us all kinds of names. They called the network and threatened to have our network access revoked because we had the nerve to challenge them. At the end of the day, to make a long story short, we paid the claim from the date of surgery on. We applied the appropriate network discount. We denied the 12 days for lack of medical necessity. And of course, the hospital cashed our check and never sued the plan, never sued us, never challenged us, because of course they had no basis to do so. So there's $70-some thousand that an ASO carrier-based TPA would have paid. Had that plan paid, would have had the stop-loss carrier paid, and they shouldn't have. So those are a couple of great examples of why an independent TPA makes a difference. So what do we do? What do we do to be innovative and provide value other than just observe and monitor claims and inject ourselves in situations like that? Well, we've also developed a robust reference-based pricing program, which we rolled out about 6 years ago, which gives employers the opportunity to present their plan to the marketplace without using a PPO network contract. We've had a lot of success with that over the past 6 years. We typically see savings in terms of medical component of their claims dollars of 30 to 35% through a reference-based pricing program where the reimbursements are based as a percentage, a multiple of the Medicare fee schedule. For the first number of years, we rolled this out as a completely free market process. no agreements with providers, either professional docs or health systems. Completely free market, making it very, very clear contractually with multiple application of notice to the providers of what the plan's reimbursement schedule would be prior to them providing care, and made sure that they would accept that prior to them providing care. And that worked very, very well for a number of years. As you all probably know, in about a year and a half to 2 years ago, hospital systems, because of the growth and success and popularity of reference-based pricing across the country, started pushing back. Not all hospital systems, but some. So it created a new climate, a new environment where there was an increase in patient balance bills and challenges to them accepting patients in certain markets and across the country. So we reacted appropriately. And now what we do is in markets where we have clients that are interested in reference-based pricing, we've pursued contracts with providers who are forward-thinking and recognize that a partnership with a payer or with employers in their community makes a lot of sense. Makes a lot of sense for a couple of reasons. One, they're getting out ahead of this inevitable curve towards that's a demand for price transparency, and they're responsibly getting out in front of that, and they're securing relationships with employers in their own communities via the contracts that we're negotiating, and it gives them one key pure advantage that they don't get from most PPO contracts, and that is that most PPO contracts are so broad. These health systems and their competing health systems, and in many cases, the big multi-state national presence health systems that they're fiercely trying to compete against because they generally do a better job on quality and price. Yet both of them, all of them, are in the PPO network. So are they getting any patient and employer health plan relationship opportunities out of that? Are they getting any true steerage through a PPO contract? The answer is absolutely not. But by direct contracting with a payer and with employers in their community, they can. So we've essentially created this narrow, for lack of a better word, network, even though it's not necessarily a network, but this direct partnership where they can work directly with employers, and we can refer them to care in their community with health systems, with ambulatory surgical centers, with specialty providers that are independent, that generally have higher outcome data, and they've agreed to contract with us and our customers on a price point that makes sense. That's better than the PPO contracting. Does it always work in every individual market? Not necessarily. Markets vary by their level of maturity and therefore the receptiveness to reference-based pricing. So a key component for you as a broker consultant is to assess those opportunities in the markets that your customers have employees. And we can help you with that. We have tools that are available to us and to our customers where we can do provider searches by geographical information, zip coding, and identify providers that are reference-based pricing and not accepting of reference-based pricing programs. And that's helpful. Sometimes we're able to really effectively manage an employer's health plan because they have 600 employees in 2 states where we've been able to negotiate contracts in their reference-based pricing, but they have another 100 employees in a state, in an area of the country that is not mature for reference-based pricing yet. Providers haven't even heard of it yet in some cases. So what we've done in those cases is put a PPO in for just those 100 employees while we cultivate the opportunity for establishing contracts so we can bring them in the fold. But if you're able to successfully lower your price point by direct contracting on 70, 80, 90% of your employees and rely on a traditional PPO contract for the balance, that's a winning proposition. You're still achieving savings for that employer. We've also done the dual option model, where an employer in the market will say, we're going to offer a reference-based pricing program, and here's contracted providers who are comfortable with the fact that we have qualities, the providers of quality, and plenty of access and choice. And here's the contribution rate and the deductible schedule of benefits plan design for that program. We're also offering a traditional PPO. We know by evidence that PPO contracts cost more. They have a higher price point. So therefore, if you choose the PPO model, your contribution rate, your payroll contribution rate is going to be higher. And oftentimes the employer will also have a higher deductible in that plan design for the PPO. It's interesting when we roll it out on that basis, and employers want to give people the flexibility of choice, but ask them to do so by putting their money where their mouth is and pay more because that design costs more. We typically see enrollment statistics in the 85 to 90% range where the participants choose the reference-based pricing program because they see providers that they would be happy with using for them and their family, and it costs them less. And after all, this is all about making healthcare more manageable. So the momentum for reference-based pricing is strong. It can't happen fast enough for all those of us that really believe in it as a matter of principle. But there, as you know, a strong move and demand towards price transparency from the federal government, forcing providers and hospitals to start to disclose their pricing. That supports the reference-based pricing model very much. And there are TPAs like ourselves, most of them independent TPAs, again, getting back to the value proposition of independent TPAs. But there are those of us around the country that are really pushing and promoting price transparency and more reasonable pricing with health systems to benefit self-funded employer health plans. So, I think I've touched on all the key points as to why working with an independent TPA can be very valuable for you as a broker consultant. If there are any questions, I'd be happy to take them. Or I know through the program here, questions can be submitted and we can respond to you at a later date if we can help you with that.
Yeah, definitely can. Thank you. So we do have a few questions, but for sake of time and the recording and that kind of stuff, we will get those questions out to everybody and make sure that you get those answered. Just wanted to thank you, Ken, for your time today. Appreciate all of your expertise and the examples that you gave, I think are concrete and give us a real good idea of what an independent TPA can do for us. And just wanted to thank everyone who attended today and have attended our previous 3 sessions. And hopefully you can get some valuable information and insight onto how to improve your self-funded plan and hopefully reduce costs and create a better experience for your employees throughout the course of 2021. So thank you, everybody. Have a great day.